60-year-old woman comes to your office and she has difficulty with activities of daily living. She says her hands feel a little bit clumsy, and she has some pain, numbness, and tingling in both arms and specifically in her hands. If a patient like this comes to your office, what kinds of questions would you be asking them?
Is this acute versus chronic?
Yes, I think the timeline of symptoms is really, really important. Time to get up. Just kidding. Steve, timeline?
How long has it been going on?
Absolutely. Yeah, knowing the timeline is important. Alexis?
Have you known injuries?
Yeah, was it in the setting of having a recent or even a remote injury? Sometimes we don't think about something that happened in the past. In her case, she did not have an injury, both recent or remote. Lindsay?
Is she having any dexterity issues, difficulty doing up buttons, pouring drinks, those kinds of things, weakness going on?
All of the above, yes. She can't button her shirt very well. Her handwriting's not as good as it used to be. Definitely having some dexterity problems. Steve?
Her comorbidities, I think, are important to look at that point. Like, does she have a history of strokes or other back problems, or what medications is she on?
Yeah, she has high blood pressure, and her BMI was about 33, 34, so maybe a little bit overweight, but no other major comorbidities. She does not have diabetes.
Are symptoms intermittent or constant?
They're pretty constant. Yeah, they've been
positions or sleeping and sitting different.
Not a lot. No, they don't come and go so much as they're just pretty consistently there. Brandy?
Things been getting worse, or are they staying about the same?
They've gotten worse. Yeah, if she were to look back at the last 6 to 9 months, they've definitely worsened. It's a really good question. Other things? Those are really good questions. Yeah.
So it's numbness and tingling. Has she lost sensation?
Yeah.
Is she temperature insensitive? Like she can't tell hot and cold?
You know, she, I don't recall on the temperature part. I didn't ask her that, but she definitely can't feel things as well as before.
So the ones that grab the pot don't know.
Yeah. I didn't get a history of her incidentally getting a burn or anything, but definitely a good one to note the severity of the sensation changes.
I also want to know where she was feeling the symptoms, if it's certain fingers or the entire glove symptom.
That's a really good question. She actually had bilateral carpal tunnel releases that did not help her, and it was her whole hand. So that's a really good one, is getting the distribution of the sensation loss. Yeah.
One hand or both hands?
Both hands.
And is the pain localized? Can you point to the spot where it hurts right here, or does it radiate something?
It's more radiating. Yeah. Those are good. Really good. Other questions? Brandy?
Having any other symptoms? Difficulty with ambulation?
Yes. She does have a little trouble walking. Like, she's not as steady on her feet. She doesn't feel as balanced. She did have a fall or two in the past 6 months. Anything else?
Other aggravating symptoms? Things make it worse or make it better?
Not really. No. She doesn't notice specific activities that are worse. That's a good one too. Yeah?
You might have answered this before, but how's her strength? Is she able to hold up a cot?
Yes, so we're going to get into the physical exam, but she feels like she's weaker. And even some of her activities of daily living, cleaning the house, making dinner, those kinds of things, are getting dressed are a little bit harder for her than they used to be. Yeah?
Has she tried anything like physical therapy?
Not really, no. She's sort of just dealt with it for the last several months prior to presentation and never really saw anybody about it. So she's kind of coming right away for the first time. She hasn't done any conservative treatment. She hasn't really even been diagnosed yet. I think somebody saw that she had hand numbness and did the carpal tunnel, but that's about all we know.
She had these in the past?
This is new. Yep. Those are great questions. So you've asked these questions. What things would you be specifically looking for on physical exam? Yeah.
Strength test, grip test.
Yes, and we, thanks to Dr. Bowden and also maybe some of the physical therapists, added a grip test, pounds per pressure, as part of our vital signs. And I think in our office, Dr. Pitts had the strongest grip strength. We had a patient that I shook hands with last week, which I shouldn't have done, and I asked what is his grip strength, and it was 160. I was like, okay, I can tell why. Hers was 30 and 25. So 30, I think, in the right hand, 25 on the left. Yeah.
There's some evidence of like upper motor neuron disease.
Yes, definitely. What specifically on that one?
Hoffman's hyperreflexia.
Good. Does everybody know what a Hoffman sign is? You sort of take their hand, let them relax, and flick the fingernail, and they'll reflexively contract the hand. And then check reflexes. Her reflexes were increased, and she did have a Hoffman's. So those are really good specific findings. Grip strength loss, increased reflexes, and Hoffman's. Anything else you would know?
Possibly like localized pain throughout the shoulders or the neck.
Yeah, you could.
Palpation or on mobility.
Yeah, stiffness, range of motion, guarding. Her neck, the neck muscles seem tight. She has limited range of motion in her neck, definitely. Yeah.
Facial expression, and sensation.
Was there a specific thing that you're looking for there?
Just like a central function.
Yeah, some sort of underlying severe neurological condition that's affecting multiple areas along the neural axis. Definitely a good thing to look for.
I probably want to watch them walk a little bit.
Yes, yeah. Her walking is a little bit unsteady. It doesn't look horrible. I don't think you would pick her out of a crowd as somebody that had a particularly abnormal gait. But one thing we don't do as much as maybe we should in clinic is walk the patients. I used to get the patients from the lobby myself, and it was part of the exam, a secret part of the exam, to watch them walk in. I don't do that now, but seeing the patients walk can be really helpful. I changed the spelling, and then we downloaded it. Don't ignore that. I know how to, anyway. What test would you? We had a problem with the PowerPoint. Anyway, what test would you order? You're at this point, you've heard the history, you've done the physical exam. I would note she does not have atrophy in her muscles, which you could look for. I think we've hit the main physical exam findings that we found. What test would you order? Yeah?
Cervical MRI.
Very good. Okay. Anything else?
X-ray.
X-ray. Good. I love that. I think we jump to the MRI and there's a lot of valuable information on X-ray and it's easy to get, so we definitely love seeing X-rays as well. Good. Would you at the outset order anything else, or would that be what you would do?
Depends on whether you're looking for zebras or horses.
Mm-hmm. It does. Yeah. What do you mean by that?
You could order a whole bunch of lab work to look for some really strange infections or other such things that are making the symptom. But at this point, it's probably not.
I was going to ask, what's your style? Do you like to just throw it all out there at the beginning, or get a couple of high-yield tests early and go from there? High-yield tests. I like that too. I think if I were answering this question, I would have just said X-rays and MRI of the cervical spine. I think it localizes there. I think that's going to be the highest yield thing, and then see what that shows and go from there. Anybody else would do that differently? Yeah.
Maybe some nerve conduction study.
Yeah, nerve conduction study, and she may have had one when she had the carpal tunnel surgery. I'm not sure, but yeah, nerve conduction study can be a good one. I probably would not have ordered that right off the bat, but I usually, and I'm not saying it's right or wrong, but I would usually preserve nerve conduction studies for when I was unsure about something. But that's definitely a valuable test. Anybody going to do a selective nerve root block? We went to a conference this weekend, and apparently it's very high risk. So, okay, so this is the MRI of her cervical spine. I've showed the axial cuts, which axials, these are actually kind of hard to really see well. I'm sorry, but what do you see on the MRI here?
She's got central stenosis with myelopathy.
Those are good big words. Yeah, I like that. So, central stenosis, I agree with that. You can see that the cord is compressed across maybe 3 or 4 segments there. What does the term myelomylation mean?
Essentially bruising the spinal cord.
Yeah, bruising, maybe thinning. You can sometimes. She has some very subtle, not sure, bright signal in the cord, T2 signal change. Sometimes you'll see a really bright signal, which is like a bruise. But the spinal cord is, I think it is a little bit thinner. And she has stenosis. Any other comments on the MRI scan?
Thickening of the OPLO due to the spondylosis in the neck. So
Okay.
that OPLO is a little thicker. Always worried about calcification. CT might be appropriate.
Yeah. So OPLL is the ossification of the posterior longitudinal ligament. There's a ligament that runs along the back of the spine there, or the back of the vertebral column. It's relevant in surgery because we go through that to get to the dura. And in some cases, that ligament can calcify. And Tyler's indicating that there's some concerns on this imaging study that ligament is actually calcified and would order a CT, which I think is really smart. Something we don't always think of. And so we did order a CT. And what do you see on the CT? Kind of what you were alluding to, right? That this area, this is all bone through here. And she has ossification of that ligament. So we're going to talk a little bit about cervical spondylotic myelopathy. This is kind of a technical term. Spondylosis is kind of another name for arthritis, I think. And it's the most common cause of spinal cord dysfunction, most common cause of spinal cord injury. And I'd like to think about it as being repetitive microtrauma to the spinal cord over time. So there's some narrowing for some reason, and the cord suffers insults over time. Central cord syndrome would be like somebody that has a narrowing and then they get bumped and all of a sudden it's way worse. But it's all on a continuum. Most of the time it presents insidiously, which means just gradually over time. Patients can not really notice it, or they don't present until they've been having symptoms for a while. Gait instability, bladder dysfunction, sometimes fine finger motor difficulties are common symptoms. And then, as we talked about, hyperreflexia, weakness. We don't check joint position sense as much as maybe we should, but alterations in joint position sense are things that you would find on physical exam. This article has actually just got published in the Spine Journal. So the question comes up in a patient like this, am I going to improve? And they looked at a bunch of patients, neck disability index with surgery, 41.5% of the patients improved. A general measure of health-related quality of life and disability, the EQ5D, 60.5% of the patients improved. The patients with a shorter duration of symptoms had a more favorable outcome. And the worse their baseline scores, the more likely they were to improve, which the article described it as being an expected finding. You have more of an opportunity for improvement. I'm going to skip this really quick. Yeah?
Did they say what the shorter duration was? Like 6 weeks?
Less than 2 years. 2 years was kind of a cutoff that they talked about. Okay. Yeah, it's a really good question. So not like 6 weeks. Yeah. So that brings me to this. So a patient that has mild symptoms that you have found on exam and on your imaging tests and history, do those patients need surgery? With duration, they've been having it for a few months, they're mild. The question is, do they need surgery? Has anybody ever heard before that the doctor told me if I didn't get surgery, I'd be paralyzed or something like that? Have you heard patients say that before? I'm seeing some heads nod. Yeah, I've heard that a lot in the last 10 years, this idea that you've got some narrowing where your spinal cord is, and if you don't do something, you're going to be paralyzed. And Alex?
I think on top of that, it's that they're at risk. They say if I trip and fall, then I'll be a paraplegic.
Yes.
It's such an increased risk of minor trauma causing catastrophic issues.
Yeah. So how do you counsel that patient?
That's not true.
Okay. Yeah. I don't think it's true. Yeah. And this article, which was published in 2015, is an example where they basically say conservative treatment is reasonable, that you don't have to feel compelled to go straight to surgery. You could trial conservative treatment, monitor symptoms if the symptoms are not progressive. So we want to identify this problem. That's part of the reason we're bringing it up, part of the reason we're asking all these questions. It's important to look for it on history and physical in patients in your clinic. Mild symptoms that are not progressive could be monitored conservatively. Yes?
I think that's tough for patients to hear, right? Because you're like, it's not so bad right now, and they're like, but is it going to get worse?
Mm-hmm.
Should I do something now because it's just going to get worse, right? The other thing you hear is like, it's just a Band-Aid doing physical therapy, right? So how do you respond to all of those questions that patients would?
That is an excellent question. What do you think?
I think talking to patients about risk-benefit stratification, right? Like with the amount of calcification at that PLL, if it is an active 60-year-old, like in your patient case, then the likelihood that it is going to progress at age 80 and the higher risk of surgery, you might as well get it done sooner would be my recommendation or thought process. But if it is already like an 82 or 85-year-old, like with, yes, I do activity, but is it like, worth it for me to undergo a major surgery?
Absolutely. So all of this comes down to risk and benefit. So mild symptoms, we know there's going to be less of an opportunity for improvement. And then what is the risk of intervention? Some of these problems are this ossification of the posterior longitudinal ligament. These are hard surgeries. They're very risky. And so that is part of the conversation. Other thoughts?
I think this is a great opportunity to set up reasonable expectations for the patient.
Yes.
While we live in Western medicine, we think we are miracle workers. The truth is that a lot of the times patients are expecting a magic wand. Like, if I do this one thing, I'm going to feel like a 16-year-old kid again, and I'll do whatever I want, never have to worry about anything ever again. Where in reality, we all know that's not true. So I think when during these early phases where you're like, I don't think this is a great idea for you to have surgery because of the risk and benefits, let's talk about these. Let's create these reasonable expectations. Now, if we play the conservative role and we're not necessarily burning any bridges, where there's still plenty of opportunities to do these other things, but we're allowing your body to do what it does best, to heal itself. And I think if you're walking patients through this process, I think the idea, the concept that there really isn't a magic wand out there for anything, part of it is this coping mechanism that, when we're younger, none of us think we're going to have this problem. One day we wake up and we're like, crap, what happened? I got old. And I think helping patients cope through that process of this isn't at all what I thought aging was going to be like, or what my life was going to be like, I think that's a very appropriate thing to do, and it's a process. It's not something that can be done magically by one surgery.
Right.
You're going to be fantastic.
Right. I like that. Carolyn?
So knowing that you kind of have this window of like 2-ish years to have a better outcome, would you like watch them every 3 months, or how frequently would you evaluate?
That's a very good question. I think that I'll just tell you what I would do in a patient with mild symptoms and mild stenosis. I think it would be fair to check in on them maybe every 6 months, keep an eye on them. I would also reiterate to them that physical therapy is a part of a good outcome. It's not the thing that you, to your point, like a magic wand. I don't think any of the therapies and treatments that we offer are magic wands. It's not a one thing that fixes everything. It's more a multiple things that you would want to be doing concurrently to have the best outcome. And so working with therapy would improve the strength in the neck. It may diminish progression of symptoms. Also, if surgery were advised or we were going to end up doing surgery, you would have likely, you'd be better prepared for it. The stronger your muscles, the stronger your bone health. I would emphasize bone health as well with nutrition and those kinds of things would lead to a better surgical outcome. So framing it that way would be the strategy. But mild symptoms, not progressive, with mild stenosis, it's safe to watch those patients and counsel with them. You could still do surgery. This article also explained that sometimes those patients can go to surgery, but you basically have options. And I think your comment on the risk is really important. If this is a low-risk situation, a younger patient versus a much older patient and a higher risk pathology, you just have to take that into consideration.
That and multidisciplinary consultation is important too, because I don't know if this is a difficult surgery or not. It's a high-risk surgery. It could be, I'm assuming it's a high risk, but you could be like, oh, it's not. Like, you know, it just extra high. It's fine. Then that changes it. So I would like to know that answer for which I would send the patient.
I would think about cervical myelopathy as a surgical problem. It is a surgical problem, and it's something that deserves a consultation. Our job is not to just operate on every single patient that comes through the door, but to counsel them and to talk about risks. And in many of the patients, I think conservative monitoring can be done. Yeah.
I think especially when we talk about physical therapy or even adjunct therapies, for this type of patient who either is undecided, maybe not appropriate, maybe not severe enough, and they come to therapy and they're like, oh, is this just a Band-Aid? And the answer really is, if you irritated it, sometimes they do, and then it waxes and wanes just a little bit. Like, our job is to help you reduce the irritation. Maybe that's postural or positional or just activity or more strength, as you already alluded to. But also, I think the key component is I tell patients, my job is to communicate with your surgeon, continue to test, and if anything starts going sideways, we're going to send you back. We're here to monitor the situation, give you good information, continue to test your strength. Like, if we see a rapid change in anything, like, we're going to just ring the bell and we're going to get you right back into the system. If you're getting better, all news, great. We all love to see patients getting better.
I love that. That's a task that all of us can have, both the detection and monitoring of lots of different pathologies, specifically myelopathy that's insidious and may gradually progress, and we want to say, 3 or 4 months ago, your grip strength was 25-50% better than it is today. I think it's starting to worsen. Okay, so when we look at this problem, so the main issues are detection. We need to detect it, and then the choice to go to surgery versus not surgery. Most of the time, I would say that the choice on surgery is somewhat straightforward. I think one of the challenges that we have is what surgery to do, because there's a lot of options. This is a relatively frail 78-year-old woman who really had a bad problem up here. We chose not to try to do a big front back multi-level fusion or big surgery. We really just addressed the main area of her stenosis and did a decompression. This patient had multi-level stenosis, with the worst of it being right here at a C4-5. So we did an anterior decompression and fusion at that level, but we also did a decompression posteriorly without fusion across a little bit more of the spine, trying to preserve motion, but also address the severity of the stenosis. This patient, also an older patient actually, multi-level severe stenosis, and so we did a multi-level laminectomy and fusion. I did this case a long time ago. I might have done it differently now, but this picture is kind of nice to show, like, what that looks like if you unroof the entire spinal canal across multiple segments. This patient had multiple levels with bruising of the cord, myomalacia, also the T2 signal change. This view is through the disc, down to the dura. You can see that the cord is free. You can actually see the pulsations of the spinal fluid through the dura. And we just did a multi-level anterior cervical fusion, watching very carefully for subsidence of cages. We did not end up having to do anything posteriorly. And then in some cases, motion can be preserved. This patient actually did yesterday, had a large disc herniation compressing the spinal cord at C3-4. And she did have some degenerative problems with more neuroforaminal stenosis down lower. And her BMI was definitely over 40. So we targeted the higher single level. You can see we could barely see 3-4 on the x-ray, but we did an artificial disc. And then multi-level cervical laminoplasty, where they unroof the spinal canal and by doing out-fracturing the lamina across multiple levels can be an effective treatment and preserve motion. This is what we did for this patient in real time. We put screws in, we went in through the back, and I decompressed above and below, or at least took the bone out and ligament out above and below. This stenosis is in the middle, so I created cuts in the bone lateral to the stenosis, and then lifted the whole thing off in one piece. That way we weren't putting anything in the canal where it was really pinched. We monitored this case with neuromonitoring. They checked motor evoked potentials every 10 minutes or so. And there was one moment, and I had done like a trivial thing where they saw a little bit of a decrease. So these are very, very sensitive surgeries. The patient had maybe half an hour later, her motors came right back, but very sensitive, so we try to be very careful. The other reason I did the fusion before is there's no movement of the spine while we're doing the decompression. So we're not, as we manipulate things, it's not like the spine is moving and bumping against the cord during that process. So once the bone was cut, there's still some ligament attachments, and so just lift it up and unroof the spinal cord. And that seemed to fully decompress the canal. After surgery, she noticed some improvement, and she came back and saw Alex in clinic last week, and it's still having some ongoing symptoms. So I think that literature is accurate, that we see about half of the patients notice a minimally clinically different improvement, but it's not a problem that we see dramatic results from. Yeah.
We always tell patients that the goal is to prevent getting
Yes. Yes.
Like if there's any improvement, that's kind of like a bonus. The goal is
Yeah, I think setting the expectations for this from the outset is important.
So this procedure, post-procedure, this patient will not have posterior osseous structures?
Mm-hmm.
Yeah, they still, the ossification's still there.
But the spinous processes are gone. Yeah.
And just so I know,
Yeah,
because I'm putting
yeah.
needles in the spine too.
Yeah, you don't want to put a needle here.
Yeah.
Yeah.
And what would this particular procedure be called?
Laminectomy and fusion.
Laminectomy.
Yep. Yeah, you would still be able to go in down low if they didn't have severe stenosis down there, but you would have there's no epidural space anymore. It's all scar
And
with no landmarks.
what are the risks for these patients when there's no like bony covering from the back?
That's a good question. It doesn't seem to be a major issue. If you did a big multi-level laminectomy, they could develop kyphosis, but we've done a fusion. This is a lot deeper than it seems, and the muscle and the soft tissues kind of go over the top. So that's a good question. The advantage of laminoplasty is all of those posterior structures are still there, but we elected in this case not to do that. That's a good question. Okay, so just in conclusion, it's important that we recognize cervical myelopathy and think about it as repetitive microtrauma to the cord, and it usually has this gradual, insidious onset. Conservative care is okay if the symptoms are mild and not progressive, and it's all of our jobs to sort of help monitor these patients. The improvement is okay. It's not awesome. And I think to Kent's point, oftentimes we're thinking, we don't want this to worsen, and it can, and we've shown that it is progressive in your case, for example. And then you can expect to see improvement, but not in every case. And then there is a lot of options for surgery. So the surgeon's job in this case is to tailor the specific recommendation for surgery to the patient, their risk, their pathology, and actually also the surgeon's technical skill set and what they are most proficient at doing. Thank you for coming today. I appreciate all of you, and have a great day.